Now that we've discussed factors that can impact treatment decisions, would you walk us through the currently available follicular lymphoma treatment approaches and who they might be right for?
Sure. So we'll start with if the newly diagnosed or untreated patient. So again, for newly diagnosed untreated, your options are the monoclonal antibody rituximab. Again, that's a CD20 monoclonal antibody that's typically given once weekly for 4 weeks and can be repeated if need be after a break. Again, that's usually reserved for patients who have minimal symptoms, low burden disease, because again, data has shown that the bulkier disease, you're likely not to have a very durable or deep response with just single agent rituximab.
Right.
Additional options include rituximab plus chemotherapy. So we have regimens such as CVP, which is Cytoxan, vincristine, and prednisone. Cytoxan, vincristine being a steroid, prednisone. Cytoxan, vincristine being a chemotherapy agent, and prednisone being a steroid. We have bendamustine, bendamustine being a chemotherapy agent. There's R-CHOP, which is Cytoxan, vincristine, adriamycin, and prednisone. And sometimes that is reserved because unlike the other two, R-CHOP can only be given once because of the accumulation of the anthracycline. You can only have so much of that in your lifetime before you run a risk of cardiac toxicity.
Oh.
And also R-CHOP, as of right now, is a standard of care for diffuse large B-cell lymphoma, which every patient with follicular lymphoma has a chance of transforming to diffuse large B-cell lymphoma at some point. So we tend to try to reserve R-CHOP if we can.
Okay.
Additionally, more recently, there was a study called Relevance, which evaluated R-chemo versus an agent called lenolidomide plus rituximab, what we call R-squared. So it was designed as a superiority study, but what it came out of it is R-squared is probably equivalent, not better than R-chemo. So that is also an option up front. Lenalidomide is a bit different from the other agents, which are all given intravenously, meaning through the vein. Lenalidomide is an oral medication that you would take 21 days on and have 7 days off. And that's given in conjunction with the rituximab. And you typically would take that for 12 cycles or about a year of treatment. Mm-hmm. Whereas the chemotherapy regimens that I mentioned before are typically given for 6 cycles, meaning you'll be taking it for a duration of 18 weeks or 24 weeks. So around 4.5 to 6 months for the chemotherapy. Right. Thereafter, it's a bit controversial, but some patients can then transition to what we call rituximab maintenance, where you would get rituximab every other month for a period of 2 to 3 years, typically 2 years, as a way to delay the return of the cancer. So our maintenance, we know, improves your progression-free survival. So the time interval to the cancer comes back. And there is no survival benefit with maintenance at this point. So it is in some ways a bit controversial, right. Especially now given the pandemic.
What about stem cell transplant? Is that an option?
So for upfront, that's usually not something that we typically do. So for stem cell transplantation, so there are 2 types of stem cell transplantation. There's one called an autologous stem cell transplantation, which is basically really a stem cell rescue. You get a high dose of chemotherapy after stem cells are collected from you, and those stem cells are given back to rescue your body from that chemo. That is typically reserved for what we call higher risk patients. So if we give you an initial upfront chemotherapy regimen, and if your cancer comes back within less than 24 months of completion of that therapy, you fall into what we call a POD24 category, which means progression of disease within 24 months. Mm. We do know those patients are at higher risk than patients who are staying remission for at least 24 months or longer. So if we look at overall survival for those POD24 patients, about half of those patients will succumb to the disease within a 5-year period, which is much, much different from what we see with the standard follicular lymphoma patients. So in that POD24 category, it does appear that autologous stem cell transplantation is beneficial in that patient population, as well as an allogeneic stem cell transplant. So an allogeneic transplant is when you get immune cells from another donor. So meaning allo, meaning from a different person. So in that sense, you get sort of temporized and they will give you donor lymphocytes, and those lymphocytes themselves will try to fight off your cancer. So an auto transplant is mainly just chemo. An allo transplant, the donor cells help fight off the cancer. There are complications to both, which is why they're not typically given up front. The allo transplant probably has more risk of complications, as we have those cells can also recognize your body as being foreign and try to fight them off because they don't originate from you. And there's also just a risk of other death from that procedure. So all those have to be taken with a bit of caution. And for the allo transplant, it's generally only recommended if you have a sibling donor because there's less much risk of complications than versus you get an unrelated donor.